afternoon, everybody. Whoa. Turn this on. Okay, yeah, good. Good afternoon. This is the Washoe County District Board of Health meeting for Thursday, April 25th. Got a nice agenda today. We're going to shoot for a new all-time record if everything works out okay. Because Steve ran such a great meeting last time, 38 minutes, and we were there and covered it all. So, Mr. Health Officer, can you call the roll, please?
Chair Novak.
Here.
Mike Brown.
Here.
Oscar Delgado. Here. Christopher Dare.
Here.
Dr. Danko.
Here.
Marsha Berkbigler is absent. Tom Young.
Here.
We have a quorum.
Good, thank you very much. Okay, next item is the pledge. Councilman Delgado, can you lead us, please?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
Okay, next item on, before we get on the agenda, and yes, this happened, and I did run into a door. And it really did. Got
You should have seen the other guy.
Yeah,
That's all I'm saying.
Yeah, right. I was getting dog food and didn't open the door big enough, so. Before it goes on. Okay, do we have one public comment from Christy Chakanua? Christy? You can walk, it's okay.
Well, I want to help you meet your goal.
Thank you.
I'm Christy Chacarolo. I'm with Keep Turkey Meadows Beautiful, and I just wanted to share with all of you that this Saturday, the day after tomorrow, we are doing our great community cleanup, which you all helped to fund, so thank you so much for your help funding that. This event has really grown beyond my wildest expectations. For the first time ever, 2 weeks ago, we were full. We had all the volunteers we needed. So we've just been adding sites. We are now up to 31 sites for the Great Community Cleanup on Saturday.
That's awesome.
I know, right? And that's to the community. I mean, we just have an incredible community here. So something we're going to be looking at for our strategic plan next year, how to engage 2,000 volunteers. At any rate, it's phenomenal community support. We're addressing illegal dump sites, historic illegal dump sites. We have found a new illegal dump site up near Golden Eagle, so we're going to be addressing that. We've got our project leader orientation tonight, and thanks to our supporters, Save Mart, Great Basin Brewing Company, and Down to Earth Composting, we are going to be turning our picnic into a zero waste event. We're very excited about this, and this is actually a sample of our reusable mugs that we're going to be giving out to the volunteers so they can use these for water or beer. And on the back, it says Washoe County Health District. So I just want to thank you guys for your support, and just know that any press you see about the great cleanup this weekend is all thanks to you, so we appreciate it.
Well, thanks, Christy. Appreciate it.
Thank you.
Chair Novak, can I mention it's probably the Great Basin Brewery beer, why you might be full?
Oh.
I'm just saying. You guys, it helps.
Before this gets out of hand, let's move on to approval of the agenda. Do you have any comments or anything?
I'd like
Yes,
to
sir.
make a comment. Can we pull item number 9? I thought we were going to pull that from it. Everything's been complied with, so can we pull that from the agenda?
I think we have an additional update of more data, so maybe if we could, if it's okay with you, I'd
Leave it
like
on?
for you to get that report.
Okay,
Okay. Then with that, I'll make a motion to approve.
okay. Second, good. Chief Brown first, Oscar second, and we're all good. Thank you, Mr. Gatto.
All in favor?
All in favor?
Aye.
Opposed? Good, thank you very much. Mr. Health Officer, recognitions?
Thank you, Mr. Chair. What I'd like to do is run through the recognitions and have everybody stay who's being recognized, and then we'll do the proclamation, and then we'll do pictures for the proclamation and the recognitions after that. So for years of service, I'd like to recognize Amber English. Amber, if you could please stand. I want to congratulate Amber and thank her for 15 years of service at the Health District with the Environmental Health Services. So congratulations.
Good.
Thank you, Amber.
Thank you.
Also, with 15 years of service, we have Julio Peck Garcia, but I don't see Julio here, so I think he is probably busy. He's in Carson City at a training. Thank you, Mr. Cutts. And with 5 years of service, Ashley Auer. Ashley, please stand. Ashley's with our Administrative Health Services program, so congratulations and thank you for your service.
Thank you.
And then we have Shining Star recipients, and these are people that were nominated for their excellent customer service or performance in the health district. And with 3 Shining Stars, we have Sonia Smith, and I don't know if Sonia is here today. Clinic, we might be a little light on some of these. Maria Rodriguez, also in the clinic. Brittany Dayton, there she is. Brittany, if you could please stand and congratulations on your Shining Stars. Heather Kerwin, there she is in the back. Congratulations, Heather. And Kimberly Graham, I don't think Kim is here, with 3 Shining Stars. And then Jackie Scheides. Jackie, if you could please stand. Jackie has an astounding 30 Shining Stars. Now, Jackie is in our WIC program and has many happy customers there. Obviously, I think she is leading the county in the number of Shining Stars that she's received, so congratulations. And with that, I'd like to, if we could move on to the proclamations.
Go right ahead.
I'd like to go down in front, and because we have a couple of people here to receive this proclamation that's on National Bike Month and Bicycle Safety Month and Washoe County Bike Month, and that's Yenling Barnes with Air Quality Management and Camarina Augusto with our Community and Clinical Health Services Division. Is this on? Yes. So the proclamation is for National Bike Month and Bicycle Safety Month and Washoe County Bike Month. Whereas promoting alternative forms of transportation, such as bicycling, helps to improve health and well-being while reducing emissions, traffic congestion, and America's dependence on fossil fuels. And whereas creating bicycle-friendly communities has been shown to improve quality of life by fostering community spirit, improving traffic safety, and stimulating economic growth. And whereas bicycle infrastructure in the Truckee Meadows offers great potential and opportunities to positively impact our recreation and tourism industry by making the region attractive to residents, visitors, and new incoming businesses who enjoy healthy lifestyles and the outdoors. And whereas Nevadans will experience the joys and benefits of bicycling during the month of May through educational and safety programs, community events, or going for an individual or group bike rides. And whereas the education of our entire community on the proper and safe operation of motor vehicles and bicycles sharing the use of streets is important to ensure the safety and respect of all users on Nevada roadways. And whereas the month of May has been declared National Bike Month since 1956, now therefore be it resolved that the Washoe County District Board of Health does hereby proclaim the month of May 2019 as National Bike Month and Bicycle Safety Month in Washoe County, Nevada, and Washoe County Bike Month, adopted this 25th day of April 2019, if that's what the board votes.
Looking for approval? All in favor? Oh. Motion.
Second.
Ready. Make this quick.
Got a motion, I'm second.
Okay, good. We have a motion on the floor. All in favor?
Aye.
Opposed? So proclaimed.
All right. Thank you very much. Why don't we commence with the photos? You're going to do them today? So let's start with the proclamation, and we're going to...
Keeping me good, so.
Steve didn't have a proclamation. Steve didn't have a proclamation.
Okay.
For his time record.
Okay. Next item is number 7, the consent agenda. Is there anything that needs to be pulled, modified, or anything on this? If not, I will entertain a motion. Motion, second. Okay, all in favor?
Aye.
Aye, good. Opposed? Passed. So we're moving right along here. Number 8, we need the representatives, from Mr. Nelson. He's going to tell us about REMSA and the accounting. And you can tell us about Mr. Dowell's vacation.
You know, I don't know much about his vacation other than that he had a good time and he made it safely back.
Oh, okay,
Which
good.
is really the, salient points for me, that he's there, he had a good time, he's refreshed, and he's back. You maybe save that for when he's up here saying, do you guys have any questions? That could be. So, good afternoon, Mr. Chairman and the rest of the board. For those of you that don't know me and for the record, again, my name is Tim Nelson, and I am the DBOH appointed CPA member to the REMSA board and also serve as the REMSA board chair. I can't believe it's 4.5 years ago now that you guys appointed me to the REMSA board. Back then we needed a little bit more clarity and transparency between the board and REMSA, and I'm very pleased to say that that has happened, at least from my standpoint, over the last 4.5 years. You guys all received in the January compliance packet the REMSA audited financial statements, which gave us the highest opinion that a company can get, the unqualified opinion. I'm happy to answer any questions that you guys have about the financial statements, but REMSA also, is continuing to value the privilege of providing the hospital care for the region, and I believe that we continue to be good stewards of our financial resources. As our entity is a not-for-profit in our public-private partnership, our revenues consist mainly of fees for service. And of course, it's very critical that we keep costs in line to work within the available means of what we are allowed for reimbursements and to fiscally conduct our business within that framework. In our January report, some of the high points is that we continue to reduce our debt by about $2.5 million last year. That was one of the former chairman's very large concerns 4.5 years ago. We continue to invest in our community through doing the education and the best-in-class training. We optimize the assets that we have by refurbishing our equipment where we can and prolonging our estimated useful lives of the equipment that we use. As our board and through the organization, we always look for opportunities, as Dean well knows, to continue to improve efficiencies and expand on patient cares. And he hates it every time we start off with the numbers and I hit him about the numbers. So I continue to do my job in driving up his adrenaline level. With that, that's really what I have to present, but I'm happy to answer any questions you have about REMSA, about its financials, or about our role within the community.
Any questions? Comments? Good, nothing.
Could I come?
Yes, you can go right ahead.
Thank you, Mr. Chair. I just wanted to acknowledge that Mr. Nelson is not just the accounting profession representative on the REMSA board, but he's now the REMSA board chairman. So I wanted to thank him for his service for that. So.
Absolutely.
Thank you very much. Big job. We appreciate that.
Thank you.
Thank you. Number 9, Ms. Conte.
Good afternoon, members of the board. I'm Christina Conti, for the record, the EMS and Public Health Preparedness Program Manager. I do have an update since this published. We have received all of the City of Reno's data, so they are up-to-date. Data per an agreement with all the jurisdictions comes in the following month on the 15th. So they are caught up, as is everybody else. So I'm available for any questions.
Comments? Well, thank you very much. This was a very welcome report, so move on. So I don't think...
Did you want to take action to change the direction of keeping this on the agenda?
Yes, that was what, you want to bring up your motion now?
Sure, I'll make a motion, we remove this from the agenda for future meetings.
Is that something that we do later? Can we do that?
We'll do it right now.
Okay, I'll second that.
Okay, second. All in favor?
Aye.
Opposed? Good, thank you.
Thank you.
And no more agenda item for a while. Thank you.
Well, I will see you next month.
Well,
The
you will,
MSAB
but
update.
not for this.
Right. Thank you.
Good, thank you. The well-rested Mr. Dow.
Good afternoon to the chair and also to the board. My name is Dean Dow, for the record, President and CEO of REMSA and CareFlight. You have before you your delivered packet of information for the organization, and I'm happy to answer any questions that you may have.
Questions?
I do.
Yes, sir.
I just want to, how are we doing on, when it comes to hiring, when it comes to us having the workers we need? We're continued, I mean, I know what the numbers are when it comes to growth and what's happening, and I also know people are stealing your workers. So how are we doing?
The movement of our personnel from our organization to other organizations, primarily the fire service, is I think, probably better today than it has been in the time that I've been here. It seems to have been, it's more balanced today. And as you know, we've helped the fire service, or 8 of the local fire departments, in the sense of developing a paramedic program based on their shift schedule. So that, I think, is going to play out well for all organizations in the future. Beyond that, right now, we're actually probably in the best position staffing-wise that I've seen the organization in the 3.5 years that we've been here. We're actually a little overstaffed on paramedics. So many of the shifts are now medic as opposed to advanced EMT and medic. But where we're finding maybe a little bit of a pinch is actually now more looking at advanced EMTs and getting quality advanced EMTs in, as opposed to paramedics, interestingly. So, but, you know, that may be something that sort of works itself out over the next several months. But
Good
we're in
deal.
good shape, actually.
Very good.
Thank you. Any other questions, comments? Take a motion to accept the report.
I'll move to approve the report
So
as
moved.
is.
Second? Okay, first and second? Okay, all in favor?
Aye.
Opposed? Thank you very much for your report. And the next part of the REMSA report, the exciting stuff.
Good afternoon. Thank you, Mr. Chairman. My name is Alexia Jobson, Public Affairs Manager for REMSA for the record. You have for your review the Public Relations Report for March. So today I'll give you an update on a couple of our more recent activities. I'm pleased to report that throughout April, REMSA received a variety of positive news coverage. Our Alpha and Omega protocols were highlighted by KTVN and KOLO. As a reminder, these protocols are a way to medically triage and distinguish between different levels of service needed by patients so that we can provide them with the best level of care and be ready to transport them to the most appropriate provider. In addition, our medically trained telecommunications specialists were highlighted for their expertise during National Telecommunications Week. All of REMSA's dispatchers are trained as EMTs or higher, and many of them have worked in the field, giving them a unique and important perspective when providing care over the phone. This was the angle of that coverage. We are particularly proud that our director, excuse me, Adam Hines, was featured by KTVN as someone to know. In addition to working as a paramedic in the field, Adam oversees REMSA's Clinical Communications Center and our Clinical Quality Department. His commitment to clinical excellence at every step of patient care is commendable, and we were thrilled to have him highlighted. Also throughout April, REMSA participated alongside the Reno Police Department and the Reno Fire Department in rescue task force training. The extensive in-service incorporated presentations, skills stations, and scenarios with live role players and high-level simulation scenarios. The purpose of the training was to work together to promote a more coordinated response to active assailant incidents and enhance community safety. Finally, on April 18th, 6 of REMSA's employees, Vanessa Coyle, Marcus Dorsey-Hurt, Matt Hoth, Kenny Kitts, Daniel Moriarty, and Jennifer Walters, visited the Nevada legislature and were honored by the Nevada Ambulance Association as Stars of Life. These outstanding healthcare professionals were selected for their high performance, dedication, clinical excellence, and important contributions to the EMS industry. They were introduced during the session and had the opportunity to meet Governor Sisolak. They joined other Stars of Life from across the state for this important occasion. I'm available to answer any questions you may have.
Questions, comments?
I have one question.
Sure, go right ahead.
So we know that we have some possible flooding on the river, not necessarily to the place it's going to harm buildings, but to the place people should not be in the river because of the high thing. Are you guys doing, and what are you guys doing right now? This weekend's going to be really beautiful and possibly problematic.
We do. We keep an eye on that, and we work with our partners, especially at the Sheriff's Department, and we will share their social media posts. We do put out occasionally some media advisories, just letting people know to stay out of the water, be safe, don't try to rescue. So we support that usually with social media and leave the more traditional media to the rescue folks.
Thank you.
Yeah.
Good, thank you. Anything else? Thank you very much.
Thank you.
Appreciate the report. Okay. Mr. Health Officer, item number 11. Tell us all about the fun in the legislature.
Well, thank you, Mr. Chair. I can't tell you all about the fun at the legislature. We'll certainly go past 38 minutes. There's been a lot of activity, and as I'm sure people are aware, Tuesday was the day that bills had to get out of the first house or be exempted or waived. And so we had a few more bills that died, and we had a number of bills that progressed. I'll just highlight some of the bills, but be happy to talk about any of them to the extent that I can. AB 66 is our Behavioral Health Policy Board's bill for crisis stabilization centers, and that bill made it out of the Assembly and is on to the Senate, so we're hopeful to see that one pass through. Actually, before I move on, I should mention that the two bills that have gone through the legislature and have been signed by the governor are both beneficial to public health. The background checks on firearms and the renewable energy portfolio standards that are those two bills. Let's see, another Behavioral Health Policy Board bill, AB 85 from the Northern Board, is on clarifying the legal 2000 NRS and removing stigmatizing language in NRS in regards to mental health. And so that also passed through to the Senate. AB 97, the bill that would provide for the public health funding, an appropriation for public health funding, did not get out of committee. That one had a $15 million appropriation on it that wasn't part of the governor's budget. So that was a decision that was made by the Assembly leadership not to move that one forward. But let me tie that together with two other bills. AB 470, which was a bill that would have provided for tobacco 21 for age of sale and incorporating vaping and e-cigs into the Clean Indoor Air Act as far as where you couldn't vape. That one also died, but we still have SB 263 on the Senate side. This is Senator Ratty's bill that would provide for licensing of e-cigarettes and vape wholesale and retailers, would impose other tobacco products tax, wholesale tax on those products, and would provide that tax revenue for public health, for distribution to district boards of health according to population, as well as supporting tobacco prevention. So there's still a public health funding bill that's alive in 263. This one has been declared exempt. And the AB 470 that had the tobacco 21 and the Clean Indoor Air Act expansion has been determined to be germane to SB 263. So that could end up being included within SB 263 as that bill proceeds. To back up to the Assembly side, AB 123, this is a bill that was for vaccinations and addressing religious and medical exemptions. We were hopeful that this bill was going to move forward in a way that the parental notification of claiming those exemptions would be required each year to be submitted to the school district. The bill has been substantially watered down, and it has some provisions that actually maybe conflict with existing NRS and with our existing authorities. And so the health authorities in the state no longer support that bill, and we'll be happy if it doesn't move through the Senate at this point. AB 231.
Real quick question on that. With what's going on with measles and things around, is this, I mean, there's some big stuff happening and growing. I mean, obviously, we've not seen it here yet, but I've seen the movies. It doesn't take long for it to get here.
Yeah.
So how, I mean, I know we're talking about this, but this has to do with that.
Yeah,
So
it's, we're very concerned about the measles. There have been a couple of cases in Clark County. I think it's 695 across the nation as of yesterday or so. And it's really disappointing to me to see what happened to this bill, because you would think in this current environment, if we were going to have some commitment to our population and public health, that something like this would move forward. The anti-vaxxers were definitely active on this. A parents coalition, kind of disguising themselves as concerned parents, really, I think, influenced the sponsor and on the Assembly side. And I don't think they realized that what they were doing wasn't really even a step forward anymore.
So my question, I've seen in other places, they've taken extreme measures because they're in an emergency situation. Do we have that in place for us, that we have emergency?
The District Board of Health has broad authorities to protect public health in Washoe County.
Okay. That's my question on this.
So
So with losing this, that we didn't lose the ability to, if we feel like there's an emergency?
Yes.
Okay.
Yeah, this board can still act. And one of the concerns that we have with AB 123 as it's written now, it provides for the school districts just providing their data to the state Division of Public and Behavioral Health. We already in statute have the authority to direct them as to what to do when they've got an outbreak, and for them to provide us that data directly, and there's no reason to set up a different structure.
Thank you.
In all of this.
That makes sense.
The AB 231, this is the bill that Charlene intervened to remove all the offensive smog provisions that would have removed the older vehicles from smog checks. So it's moved forward with all that, all those provisions removed, and we expect it to continue to remain that way. AB 430, we were concerned about this bill because it would have established for the state to work with local programs and agencies to implement home visiting programs. And as you'll recall, we were pursuing grant funding for a home visiting program that we weren't able to obtain and didn't have the match to cover, which would have cost us over $1 million a year to do the home visiting program. So we were concerned that this was an unfunded mandate. The bill has now been amended to instead look at more of a study approach to home visiting programs and how the state might be able to best support and work with local agencies to be able to provide that. On the Senate side, SB 37, this is one that's part of our CHIP for behavioral health to support. It's a bill that expands the scope of practice for marriage and family therapists and clinical professional counselors to be able to treat counsel for psychotic disorders. So I think mentioned before, we're the only state in the nation that doesn't allow them to do that. And so it's a huge disincentive for those professionals to locate in Nevada. So that's moved forward to the Assembly. SB 66 and 68 are a couple of preparedness bills that we support. 67, I think we're neutral on. All those are moving forward to the Assembly. SB 171 is a bill we also support as far as access to health care and behavioral health services. It's one that expands the data collection by the licensing boards, so we have a better idea of who's practicing in which professions and if they're providing those, actually providing those services or just licensed, and hopefully be able to collect data from that expansion of the data set on who's accepting Medicaid. So a better picture of what's really available for our citizens. I mentioned SB 263. SB 418 is a bill that would allow for raw milk to be sold in Nevada, and all of the health authorities in the state and the Department of Agriculture are very concerned about this bill, and in fact, we're very fearful of it. There is no way that we can develop a regulatory approach that would be sufficient to protect our citizens from being sickened and potentially dying from consuming raw milk. And so this bill has gone through the Senate, and we're working on a two-pronged approach. One, to try to at least get as much as we can in the bill as far as regulatory oversight and protections to reduce that threat to the extent that we can, because we just feel like we have to do that in case it goes through, but we're not moving to neutral. There's some discussion we had the other day of, well, if you're working with them to try to amend the bill, then you need to support it. And no, we're not going to make that choice. The health authorities are going to remain opposed to this bill, even though we're also working to try to have the protections that we could get in that bill if it moves forward. And then SB 448, this is the Affordable Housing Tax Credit Bill that moved forward. That's provides the $10 million of transferable tax credits per year for the next 4 years for supporting affordable housing. There's a bill as well that's moved forward that I didn't pull the bill number, so I apologize for that before we got here, and that's the family planning bill. So it's a bill that provides state funding for family planning programs, and the bill was amended from a $6 million appropriation per year to a $3 million appropriation per year for family planning, and that's what is in the governor's budget, and he had announced that during his State of the State address. So we expect to see that then proceed, and We have had some funding reductions of the Title X funding that we received for family planning, and so we're pleased to see this bill moving forward, and we intend to apply for and receive some of that, the funding to support family planning. So that's my summary on the legislation, but there's lots and lots going on. On the spreadsheet, all of the rows that are marked in that gray or purplish type color are the dead bills. And I would propose that we will remove these for future reports, since you got to see what's not there anymore, and at least shrink this down a little bit.
Good. So good. Any questions, comments? Good. Thank you very much, sir. Moving on to item number 12, staff reports. Do we need to accept?
Mr. Chair, yes. The district health officer has asked with us that the reports be approved.
I'm sorry, thank you very much. Okay, we need to have a
Move to accept the
motion.
report.
Accept the report. Okay, first and second. We got it, thank you.
All in.
Got to vote?
Yeah, we will. All in favor?
Aye.
Opposed? Bill, accept the report, thank you. Now we'll move on. Ms. Halby.
Good afternoon, Mr. Chair, members of the board. For the record, Charlene Albee, I am the, I don't even know what to call myself now. The
Very good.
Wonder Woman.
post Air Quality Management Division Director. The report in front of you today actually includes a statement in the program update that the data certification was submitted to EPA this last month. That's the data from all of our monitoring sites, so that we look at it, we do our QA/QC, make sure it's all valid data, submitted to EPA. They review it and certify it. The update for that is that as a result of our last year, 2018, we now have 3 ozone monitors that are violating the ambient air quality standard. So that really is our first step to non-attainment of those standards. What we are going to do is focus resources now on submitting an initial notification to EPA. The target is by July 1st. There's some supplementing support documentation that has to be put together. So it's a little bit of an effort to get that initial notification in to flag the fire impacted data. So the wildfire season last year was exceptional, and we did have a tremendous amount of smoke impact. So I don't think that we will have a problem demonstrating that there was data impacted by smoke. The challenge that we have is EPA is giving direction to not follow through with the second part of that and actually submitting the full exceptional events demonstration. Reason is they don't want to see those until they're ready to do another determination through the regulatory process on designations for attainment or not. The ozone standard is set to be reviewed in 2020 by EPA, which means that by 2021 we'll be going through the designation process again. Through conversations in-house and then also on some national conference calls and Western regional conference calls, we are going to go ahead and put together an exceptional events demonstration packet so it's ready. And we will submit a draft copy to EPA, and if they choose not to acknowledge it or recognize it, then at least it's on their shelf. Then when we get to the designations in 2020 and start looking at that, we'll already have stuff in the door so that if they come back with you have 6 months to get all your designations in, like they did last time for the 2015 standard, we'll be one step ahead. And hopefully that will improve our chances. The next designations, all the designations are based on 3 years. So for 2020, when they look at it in 2021, it'll be 2018, 19, and 20. So at least we'll have 18 taken care of. And the plan is to do the same thing for 19 and 20, assuming there's a fire season in both those years. So we want to make sure that you as the board know that we're doing everything possible to keep Washoe County in attainment based on the 2 criteria that I continue to say. It's not only the public health of our citizens and our visitors, but it's also our economic health, that if we go into non-attainment, we know there will be economic impacts with growth. And so we are giving it our all to make sure that that doesn't happen. And with that, I'm available if anybody has any other questions.
Questions, comments? Good. Thank you very much.
Thank you.
Okay. Mr. Cutts.
Good afternoon, Mr. Chair, members of the Board of Health. Steve Cutts, Division Director for CCHS for the record. I have nothing further to add regarding my report, but I'm going to introduce Ms. Jennifer Howell to talk more about our National STD Awareness Month. But before I do that, I would be happy to answer any questions you may have regarding the CCHS report.
All good. Questions?
Am I allowed to say?
Sure.
Congratulations. You won that big award I was at. He's really cool. A lot of people took pictures of him. He's an awarded man. Good job.
Yes.
You represent us well.
Thank you very much, Councilman Dare. Mr. Dick will talk more about that in a little bit. Thank
Is your
you.
face red?
A little bit, yes. I know it's hard to embarrass me too. So. All right, with that, I am going to turn this over to Ms. Jennifer Howell. Jennifer is our Sexual Health Program Coordinator. Had the excellent fortune to hire Jennifer 19 years ago. As I just clarified with her, Jen does absolutely amazing work and has been one of my best hires I have ever made. She is incredibly knowledgeable, passionate, and very dedicated to public health and the promotion of sexual health. So with that, I will turn it over to Ms. Jennifer Howell, and she will dazzle you with her PowerPoint presentation.
Good afternoon, Mr. Chair and members of the board. Jennifer Howell for the record. I have included a lot of the same slides that were in your report, but I wanted to expand on a few things. So STDs, or you'll hear STDs, I say STDs, old school. You'll hear sexually transmitted infections or STIs. CDC still uses the term STDs. And we can, if you'd like to contact me, we can talk about the reasons between the two. But Steve and I feel very strongly about continuing with what CDC uses, which is sexually transmitted diseases. Nationally, we look at the reportable STDs, which are chlamydia, gonorrhea, and syphilis. And there's a huge impact. And direct medical costs alone are $16 billion a year. Those are just direct medical costs. That's not the cost of going to an appointment, transportation, time off of work, those kinds of things. So there's a tremendous burden on our economy due to this. Clinics have been closing across the United States due to decreased funding sources. The recession had a huge impact on that. Political landscape has an impact. And for example, in Indiana, there was an HIV outbreak of over 200 cases. And this happened in a county where testing resources had been eliminated. And if there had been the HIV testing provider and testing resources, they probably would have been able to pick up on that outbreak a lot sooner. It did transfer over to other states. It was right on the border of Indiana and Kentucky, and it was related to injection drug use, but then there was sexual transmission as well. So a lot of HIV testing providers may not offer STD testing. HOPE's Change Point program, which is the Harm Reduction Center at HOPE's, the syringe service program, they just recently started offering STD testing in their free testing of, they were doing HIV and Hep C, and just in February started offering STD testing as well. So it's very limited who provides STD testing. And that funding, goes back to funding, it's remained static or decreased. Sad state of affairs with providers. Only about a third of providers ask about sexual history or risk, and patients are waiting for the providers to ask them about that. So the providers don't bring it up, the patients don't bring it up, it's not brought up. And with most STDs, or a lot of the times not having symptoms, then there's no reason for someone to bring it up, and that's how it gets spread. A lot of times people think that standard blood tests or physicals include STD testing. They're like, oh, I got tested for everything. You didn't, probably. you needed to ask, or your provider needed to tell you that that was being included. Drug-resistant gonorrhea is becoming a very big concern, and we're at the last line of medications for gonorrhea. There are some in the research and development pipeline, but they're pretty far out from being approved. And so it's really important for providers to treat appropriately and not veer from the STD treatment guidelines that CDC puts out, which they tend to do, because that can contribute to drug resistance. Nationally, over half of the cases occur in people under the age of 25, so people just starting out their sexual experience in their lifetime, and they have a great burden of disease. So nationally, cases have increased across the country. Chlamydia, 22%, gonorrhea, 67%, and then syphilis, which you've heard a lot about over the years, 76% nationally. And this is from 2013, and that's about when our August 2013 is when our syphilis issue hit. So some of the consequences, it depends on the disease, but there could be infertility issues for men and women. It could be fatal. And then transmission to babies during pregnancy or delivery. And one that people don't think about a lot is if a person has an STD, they're 3 to 5 times more likely to get HIV if they're exposed. That's a huge concern. And then vice versa, if someone has HIV, they're 3 to 5 times more likely to get an STD. So in Washoe County, chlamydia, I just call it the slow, steady increase. It's been 5 to 10% a year. It just keeps climbing. It's overwhelming, and it's just been what it is. Gonorrhea had a huge increase, and the reason I put 2012 data here is so you can see what happened. 2012 was like this really great year, and then everything just took off. So gonorrhea has increased 296% from 2012 to 2018. A lot of the cases for gonorrhea and chlamydia are asymptomatic, especially for females. And then providers have been referring a lot of their clients to the health district for testing and treatment because they don't feel comfortable doing the testing, or they're like, if they don't do adequate treatment, they're like, go to the health district, they'll do it for you. With syphilis, they're not carrying the Bisolin treatment, which is expensive and understandable, but then people get sent here for treatment. Or if we found the provider wasn't following the CDC treatment guidelines, then we bring the patient in. We offer the provider the opportunity to do appropriate treatment. Sometimes that doesn't go over too well with them. And then if they will not follow the recommendations, then we ask the patient to come in and we do the treatment along with their contacts or their partners. We've had to make some changes. Because of the huge increase in syphilis, syphilis is very labor intensive to investigate, and it's a very prolonged investigation. So because of that, we had to make changes based on our resources. And we started reducing the number of cases that we were investigating. So chlamydia and gonorrhea, at one point, we had target populations. We were only investigating within those. Now, it's just way too overwhelming. So as of April 1st of this year, we are not investigating chlamydia cases. We will verify treatment and bring people in for appropriate treatment if necessary, but we're not asking people to give us the names of their contacts. And we're asking clients to tell their partners to get tested and treated. And that's a huge change for us. It's caused a lot of heartburn for our staff, but just with the burden of disease, we're just not able to accommodate those investigations anymore. With gonorrhea, we had limited investigations for about a year, and then with consultation from Dr. Todd, Lei Chen, we decided to go back to investigating all of gonorrhea cases so we can monitor for drug resistance. So for example, if someone, we test and treat all the contacts, and then somebody comes back when they do their 3-month follow-up testing and they're positive, we see if it's a reinfection or if it's truly a treatment failure. If it's a treatment failure, then people are cultured at various sites. And that information, or those cultures are sent to the state lab. If that grows anything, then it's sent to CDC to see if it's a drug-resistant strain. We've sent 2 off, and neither of them were drug-resistant. But the drug resistance is coming from the Asian countries over, so California's already been experiencing it, so it's just a matter of time before we do here. So there's syphilis. As I said, cases have increased since 2013. Most of our cases are among men. About over half of those are men who actually reported having sex with other men. Anecdotally, we know that information is a lot higher. These are just people that actually reported that risk. They either reported that they were gay or bisexual, or that they had sex with other men. There are many men who have sex with men who do not identify as being gay or bisexual. They identify as heterosexual, straight. And that has been the push of disease for HIV and STDs, especially with syphilis right now. So that's a huge challenge for us. When we ask men that are in that situation who their partners are, they will only name their female partner. They won't name their male partners. And so we can't stop the transmission, spread of disease because of that. And that goes back to stigma, discrimination, internalized stigma, homophobia, that kind of thing, where people won't access services that they need to. Syphilis cases are infectious through the first year of infection. The problem is that if a person doesn't see the symptoms or they're just not aware of them, they may be within that first year, and we may have to diagnose it as a latent stage because we just don't know how long a person has had it. The diagnosis has to go by symptoms or a previous negative test, and that can get very tricky. So there could be people in our latent syphilis unknown duration category that are infectious, but we're not able to diagnose it appropriately because of those issues. Interesting to know, our female cases have increased over 400% from 2016 to 2018. And we've seen an increase in congenital cases since then. So right here you can see the congenital cases at the top don't really show up very well. It's not a huge number, but it is huge in terms of impact. And I'll talk about the response to that in a minute, but we haven't seen a congenital syphilis for I don't even know how long, a case here, until 2014. And in 2006, Las Vegas had their first outbreak, and they had 18 congenital syphilis cases that year. They had a 1,000% increase in cases in that first outbreak. So at that time, a state law, there was advocacy done on public health level to change the state law to require 3rd trimester testing for syphilis. Providers didn't really get good education on that from the state level, and so a lot of providers are unaware of that requirement, which we've been battling against. If people in the ideal world got their prenatal testing, got their prenatal care, and they followed up, again, in the ideal world, we wouldn't have the congenital cases that we do across the state. And now we're number 2 in the country in congenital syphilis, following Louisiana, which is mind-blowing. We're number 1 in primary and secondary syphilis. So this is just a depiction of the number of male cases. That's in orange, and then the number that identified men who have sex with, or the risk of men who have sex with men compared to female cases. If you think back to when I said most cases of STDs nationally occur in people under the age of 25, with syphilis, that hasn't followed the trend. So we have the 25 to 29-year-old age group, as well as the 40 to 49-year-old age group that are just neck and neck with each other, basically. And so it's really spreading across the age distribution. The connection to HIV is fairly great. You'll see in your packet there's this really great slide or table chart that shows an increase of infectious syphilis, and we haven't seen the same increase of HIV, which we're very thankful for. especially because about 30% of our syphilis cases are HIV positive, but most of those are people that were previously diagnosed. And what we think this is attributed to is the whole, not idea, but the evidence that has come out that if a person's HIV viral load is at an undetectable level, they will not transmit the virus to other people. We have more and more people that are on their medication, they are at that undetectable level, and so they're not transmitting HIV. So they're able to have unprotected sex without the fear of transmitting HIV. And they've done a lot of hard work in their lives to be able to have that adherence. And so we have the increase of STDs. And from people that are in my lives with HIV and that I talk to, and personally and professionally, they're like, I would rather get treatment for syphilis, even though that's not a fun treatment, than being expected to wear condoms all the time when I'm not going to transmit HIV. So it's a very big issue, or factor, I should say. So what is our response? Investigations are very difficult. Partner information is lacking. People will not give us partner names. If they do, it could be a screen name. And it gets very difficult. People change their screen names all the time. So with social media and dating apps, there's the sense of anonymity, or people just don't want to tell us. And we were in this whole trend of people really sharing information on their contacts. And then syphilis came, and we're back to nobody tells us really a whole lot. So what do we need to do? We brought this question to the CDC when we had a site visit a few years ago, and they said really focus on the HIV status of the STD case. So if a person's HIV positive, make sure they're linked and retained into care to bring that viral load down so they won't transmit the virus. If we don't know their status, then make sure that they were tested. There are a lot of providers that will have a positive syphilis case or chlamydia, gonorrhea, and they have not done an HIV test. And so we try to bridge that gap. And then if a person is negative, offer PrEP to them. PrEP is pre-exposure prophylaxis. Oop, it's back here. Okay, so I'll get into PrEP. It's pre-exposure prophylaxis that can prevent the transmission of HIV by over 96%, sexual transmission. And then among drug use for sharing of needles, over 70%. There has been a statewide work group convened to address syphilis, and really the increase of congenital syphilis spurred this. Lots of concerns about that. And this campaign is two-pronged. It's a provider focus, where appropriate testing is done and appropriate treatment, and then appropriate reporting to the health authority where that provider is. And then for pregnant women, really emphasizing the need for prenatal care so they can get that testing done in the first and third trimester. There's been an ongoing analysis of our congenital syphilis cases. Most of them have had inconsistent prenatal care or no prenatal care, drop-in deliveries, and then lots of polydrug use, particularly meth. So PrEP, pre-exposure prophylaxis, between this and the whole idea of U equals U, undetectable is untransmittable, that's what the CDC is focusing on to stop the epidemic of HIV. And we need to stop it because it costs a lot, and the whole social justice aspect of it, we have the tools to stop it, we need to do so. It's a daily medication, and it's a pretty regimented recommendations that go along with it. A person has to have a negative HIV test, and every 3 months, and then a series of other tests to test liver function, kidney function, pregnancy, that kind of thing. And then every 3 months, there's an HIV test and an STD test as follow-up. The recommendation is before a person gets a refill, they have that testing done. What we found is that providers in our community are maybe refilling PrEP prescriptions or writing PrEP prescriptions, and this is just anecdotal data. It's really hard to ask providers what they're doing, which I'll get into in a second. But what we found is that they're not doing the follow-up testing. While STDs are increasing and people say, oh, it's because of PrEP and U equals U, what it does provide if people follow the recommendations for testing is an opportunity to intervene with STDs sooner and to get those appropriately treated sooner, because the person would be testing every 3 months if they're on PrEP. That's not happening. So there was a survey done by the UNR HIV class last semester. We're just getting the data from it, and this was sent to every MD, DO, PA, I think, and nurse practitioner. Do you recall getting the survey? Oh, it was sent by email, okay. It was sent out by the state and the class. There were, of all of that number, there were 414 responses statewide. 123 providers said that they offered PrEP. Some of those providers said they offered it, but didn't put any contact information as to who they were. So only 64 did. The whole idea was to see who would be interested in putting their information into a PrEP directory. And the way that the survey was designed, we really are going to have to redo it to get information that would be helpful. It just wasn't well designed, unfortunately. And then post-exposure prophylaxis, statewide, 43 providers said that they offer post-exposure prophylaxis after an HIV exposure. In Washoe County, 19 providers said that they offered PrEP. Some of the names on that list, I know that they don't, because I've had people that have gone there and asked for PrEP and they haven't gotten it. And then providers that offer PEP, 13 providers. Let me give you an idea of one story. We had a person contact us to get post-exposure prophylaxis. He had gone to every emergency room. He'd even gone to Concentra because they have experience with that, with occupational exposure, and he was denied post-exposure prophylaxis. Luckily, we were able to get him into HOPES right at the end of the 72-hour window that's required for that. And he's a very vocal person, so I can't imagine the people that do seek out those services and don't get them that don't say anything. So that was a very eye-opening experience for us. The providers that we refer to in Washoe County, it's HOPES, and Dr. Zell is our medical director. With Dr. Zell, a person needs to be able to seek out care at Renown with their insurance. With HOPES, they just started a PrEP clinic through the Change Point program, which happens every Tuesday afternoon. But prior to that, a person would have to call at 8 o'clock in the morning to get a new patient appointment for the next day. And if those were filled, you'd have to call the next day at 8 o'clock and the next day. And this isn't just for PrEP, this is just to get into HOPES as a new patient. We have a person that has shared with us that it took them over 3 weeks to get that appointment, and they called every morning at 8 o'clock. So it's a huge challenge. And then for, again, private providers, the challenge is we don't know who's prescribing, and we don't know if recommendations are being followed, but based on what people tell us, they're not. So how do we build this up into a more comprehensive approach? We need more provider engagement, getting providers to care about the impact of STDs and HIV in our community. Personal responsibility, asking people to get tested and reduce their risk in whatever way that is appropriate for their situation. The support of comprehensive, inclusive, medically accurate sexual health education in schools. This is of utmost importance because a lot of these things can be prevented if there's just proper education about the impact of STDs from the beginning. And there's a concern from parents that they don't want their kids to learn this information and learn it early. But then at what point do they learn the information? Because at some point, they're going to be on their own. And what studies have found is that when kids are out of that structure of maybe a faith-based structure or a very conservative structure, and they're on their own, they don't know what to do, and they have more STDs and more pregnancy. So it's a concern, and not everybody has the parental support and the foundation that would help work through sexual health issues. And so they should have access to this information in the place where we have kids all together, which are schools. And then PrEP, and then treatment is prevention, or U equals U, to end new HIV infections will really help address STDs as well, because then we can have ongoing assessment and treatment or testing of STDs. That comes down to access issues, which comes down to money, that's the basis of everything. So with that in mind, I would like to answer any questions that you may have.
Questions? Okay, good. Thank you very much.
I have a question.
Oh, go ahead.
I'm sorry.
I have a few questions. I think you answered some of them at the end. I'm glad that we're looking at trying to do some campaigns. I'm a little concerned that our providers I don't feel that we're having the relationship that maybe we need to have. However, I'm not blaming us, whoever that is. I'd like to, I don't know, I think we need to visit the idea, how do we do that? I think we need to find a better way to do that. If we're doing all this work, and they'll probably say they're doing all this work, so together, obviously it's not working together. So that if we could shift on that. But I just say for our staffing, something you mentioned is that we're not making calls anymore, and I'm not here to tell staff what to do. That's not necessarily my job. But I question, is this a time for us to back away from that when everything else seems to not be working? I'd question if it's a staffing issue, and maybe that's not it, but if it's a staffing issue, I would just encourage you to look at that and say, this is maybe not the time for us to cut back on finding them and calling. If that, this is going the wrong direction. We don't have the components. It just doesn't make sense to me that we're at that point saying, well, and we're taking a step back as well. It doesn't make sense to me strategically.
So if I could respond to that, it's not that we're cutting staffing and therefore we're not responding to those calls. This STDs is the area that we have been increasing staffing year over year, and yet in spite of that, because we're seeing so much, we're not able to keep up with it. So the two new staff positions that we've got in the budget for next year are both in support of the sexual health program. And we've shifted resources in past budget years from the epidemiology program to STD program, and added a position previously as well. So it's not that we're cutting the follow-up because we're not staffing that program. It's just in spite of increased staffing, we can't keep up with what's happening.
I appreciate that, but I'm going to still say it. I'm just speaking as a board member here, so you guys do what you want with it.
Issue, but providers are busy. They are within the confines of time and resources as well, and we identify that. You don't get 15 minutes with your provider that's billed, you get 5. And so when we bring in preceptors from the School of Medicine, or preceptees, and I'm like, you need to really focus on this, and they're like, well, I have to focus on all this, and in a primary care visit. So that's great, but maybe unreasonable. So I need my patient to tell me what they need. But we don't have them. So we do need provider engagement. We need people to understand their personal risk. That happens through education, whether it's media outreach or whether it's the education in the schools where people are like, yeah, this fits what's happening with me. I need to go get this treatment. Or they think back to, when I was in high school, I remember this class, and I remember that I may not have STDs all the time, or symptoms all the time, but I'm having sex, so I need to get tested. Those are the things that are lacking, and there's bigger issues behind that. In terms of resources here, just the complexity of syphilis has really just turned the boat around. Chlamydia infections, those investigations are fairly simple, but there's just so many of them. And then we have congenital syphilis as a thing that we're really trying to prevent, and that takes a lot of time and effort. So Resources would be great. I just don't know how many resources would be enough. In California, they haven't investigated chlamydia, and I don't even know how long, because many, many years, because it's just too much. So ideally, it would be a whole host of things.
Well, it's certainly complicated, but.
It is very complicated. Yeah. Thank you.
Okay.
I do have a question.
Yeah.
Thank you for your presentation. I have a question about how are you engaging those providers in the community? And is there a role for things like pamphlets maybe that would educate patients while they have very often plenty of time in the waiting rooms, or even in the rooms waiting for the providers to come in, maybe doing posters or things like that, either printed from the CDC or from the Washoe County Health District, because even if providers can't add another 5 minutes or another 2 minutes or even sometimes 30 seconds to the visit itself, sometimes having that poster up or having a series of pamphlets, then the patient can say, I'm interested in this, and then at least have that linkage. Is that something that could be considered?
Sure. So Jennifer Hall for the record. Yes, definitely. And part of that statewide campaign is to put flyers, posters in waiting rooms. But again, that's very targeted to dealing with congenital syphilis. Resource-wise, we'd love to do media campaigns and things to do that, and we're very open to that. It's just finding those resources and putting them all together to be able to create that package, and having the manpower to get them out to the providers and that kind of thing.
Okay. And what about the student health center at the campus? Because I know that's serving quite a bit of the college population, which I know is the age group you were talking about.
Yes,
the most.
Jennifer Hall for the record. They're actually very engaged. I've gone and done presentations on extragenital testing, so that's testing in the pharynx, pharyngeal testing, rectal testing, and penile vaginal testing, and the importance of that. And then they open up the opportunities to do that. They have a free testing once a week. The providers, we have a DIS assigned to there, so we build that relationship with groups of providers, and Dr. Hugs is just amazing with that. So they're really a great partner. And then we have Ina Jennings, their health educator, who used to actually work here. And so I go in and train their peer educators on STDs, and then also how to appropriately ask sexual health questions.
Do you want to add to it now?
I did, yes. Steve Cutts for the record. So just a couple of things speaking to Councilman Dare. So yes, we would love to investigate every case of STD that comes through. As Ms. Howell said, unfortunately, it is standard practice to not routinely investigate chlamydia. As you saw by the numbers, there are thousands of cases. California probably has tens of thousands of cases. So it's understandable why they are unable to investigate. If we had unlimited resources, and if the burden of disease shifts, or if it starts to come back down, the numbers of STDs, we look forward to doing full investigations of the priority groups that we had done previously. Also wanted to add to what our health officer, Mr. Dick, had said about shifting resources. We also shifted a public health nurse who was split between our tuberculosis program and our immunization program. And we have also reclassified and added other staff along the way. So I appreciate you saying, we're adding staff this coming fiscal year, so we should ask for 3 or 4. I always go in with a big ask, as Mr. Dick and Ms. Heenan will tell you. I try to be reasonable. I expect that there will be more asks in the next fiscal year, highly likely for the sexual health program. But anytime we have a vacancy, and if we are able to shift that vacancy, we're not always able to do that because often it's tied to grant funding, and we have grant deliverables and scopes of work to adhere to. But if it's locally funded, we look at where we need to have that staff member assigned to, and if it is appropriately classified. So sometimes we will reclassify, say, a public health nurse position we have reclassed it up to an advanced practice registered nurse. We've also reclassified it to a public health investigator that is not in the clinic but can do more of the investigation and the data entry, which that has become very burdensome as well when it comes to STD investigations.
Councilman Dialga.
Thank you, Mr. Chairman. Quick question. In your presentation, good presentation, I didn't really see more focus on demographics. And so is that key in terms of what you guys are finding? Are certain demographics, certain populations more impacted than others? And how are we targeting in terms of doing more focused PR or awareness campaigns there?
So thank you for the question, Jennifer Howell, for the record. Definitely in communities of color, there are higher burdens of HIV and STDs, particularly Latinos and Blacks. So testing and outreach-wise, we look at where we can do brochures, those kinds of things. We have done testing at the Family Health Festivals. With the new funding stream that we had through our Ryan White funding, even though that's an HIV care funding source, there's an HIV testing component to that. And our niche is to test in communities of color and increase that testing. So we've been working on doing that and engaging some non-traditional partners. When we do HIV testing, we always do STD testing. It's one and the same. So for us.
In terms of percentages within those populations, what are you seeing overall? Are you seeing, do you have any statistics in terms of percentages of what we're talking about here?
The 2018 data for the Communicable Disease Annual Report is being compiled, but it's a really well established in the 2017 Communicable Disease Annual Report. So HIV-wise, we have fewer numbers, but you'll see a disproportionate burden of disease. It could be like 20% of our cases could be Hispanics or Latinos, and that's about 20-25% of our population.
Sure. So. And Mr. Chairman and Board, the reason for my question is more of a, I think generally speaking, we've seen white papers throughout showing the impacts to some of these populations, and for us to consider when is the benchmark, when is the tipping point, when do we start looking in terms of crises within certain populations, and when do we direct some of those resources to those populations versus a broad range of outreach. And so, and so that's something for us to consider, something for our community to consider. I know it gets very complex, very quick when you engage with communities that are new to our community or society and engaging. And it's also a reflection about how we engage in our staffing as well, right? So it gets complicated, but things for us to think about, and that's why I look at in terms of the presentations. And again, thank you for your presentation. Look forward to that data as it comes back in terms of how we can focus in a little bit more.
I agree with Councilman Delgado very much. And is it possible to have brought back to us? It'd probably be good to see the demographics of growth. And so, because I do agree, we do this a lot of times where sometimes looking at the whole thing, it just seems like we never really get anywhere, And so not that you don't do some for everything, but maybe you really take and hone in if there's one population that is growing on a faster level, maybe we would see where we could help the whole combination if we really found a way relationally to focus on that. And it might be a wise thing to look at, but it'd be nice to see some numbers to actually be able to make a wise decision.
I agree, Jennifer Howell, for the record. One thing that HIV prevention, CDC mandates HIV prevention to do is look at high impact prevention. And we have to look at populations that have a current burden of disease, not who we think is going to. Mm-hmm. So we do limit our outreach to where that burden of disease is. And that's men who have sex with men, and then in communities of color. That's why when the opportunity came up to expand our HIV testing and by proxy our STD testing, we took that for the communities of color because it opened up that opportunity. With the prioritization of disease investigation that we had for chlamydia and gonorrhea, it was HIV positive people, pregnant females, people under the age of 25, men who have sex with men, and then the African American Black community because of the burden of disease and of gonorrhea. So, and at one point it was every Native American case that was reported to us because we had noticed an increase of cases there. And then we do reach out to providers, say the Reno Tribal, or Reno Sparks Indian Colony Clinic, that kind of thing, to say, hey, how can we address this? Can we increase testing? Is there something we can do to help? So we could do better.
Thank you.
Thank you.
Anything else? Good. Thank you very much. Okay. Do you want to take the next one?
So as we move on to environmental health, I wanted to let the listening audience know, I informed the board the other day that Mr. Westham, our former division director for environmental health, resigned to pursue other career opportunities. His official last day is tomorrow, but he's burning up a little bit of leave today and tomorrow. So Ms. Albee has agreed to be the acting Environmental Health Services Division Director in the interim as we find a person to fill that position permanently. So that's why she's standing before you for this report, and I wanted to thank Ms. Albee for agreeing to do that.
Thank you. For the record, Charlene Albee, Acting Division Director for Environmental Health Services. I did want to first note that I truly feel the only reason that this is possible for me to successfully do this is the strength of the Air Quality Division. We've got 2 supervisors who were more than willing to step up to the plate, and every single staff member also said that they would be willing to go above and beyond to support the division in my absence. And so knowing and having the peace of mind that that's being taken care of, I will still engage with division leadership meetings over there so that I can stay on top of things so that when we are successful in getting a new EHS director, I'll be able to slide right back in. And those guys are really being very supportive, and I appreciate it. In preparation for this transition today, I wanted to let you know what's already happened. On Monday, I met with the fiscal compliance officer. We went through all of the budgets and the grants. I also met with the supervisors and basically gave them my expectations and got feedback from them on where we are and where they need to be and challenges and opportunities I believe that we have. This morning, we had the EHS general staff meeting, and so I was able to address the entire staff. Had lots of good conversation, was very well received, was a very positive meeting. I think that there were a few things hanging out there that we were able to clarify so that everybody's on the same page, has the same direction. And then right after that, I had a meeting with tech services, and we were able to go through and just confirm the priorities for the Excella development, so as we're continuing down that path. So the last piece is, as a result of Mr. Dick's email yesterday, Jennifer Carr, the Deputy Administrator of NDEP, actually sent me an email last night. We were conversing, and she is going to be in Reno next Monday, the 1st, and is actually going to come by and see me so that we can sit down and we can get caught up on the land development and some of those, the Tumwa ILA things, just to make sure that I'm up to speed and can facilitate that continuing down in a positive direction for everybody, especially the development community. So with that, I haven't been doing anything else. So I will take your questions and promise to come back with an answer if I don't have one for you right now.
Right.
So this is an area, as you know, that like it or not, it's the community that is watching this area very much. And I would encourage us all to make sure that we just communicate very large if there's changes, shifting. I know that this is an area that's gotten attention in the last year or two, to the place where I know Councilman Delgado and myself don't really like having to talk about this one anymore because it's just so often. But we've made a lot of strides in the right direction. And thanks to Director Kevin Dick. I just really, I mean that. We're moving in the right direction in many ways. But I can tell you there's still some hiccups out there, and relationally we can go back. So just, I thank you for stepping in, and I definitely think you'll do a great job like you do anything else. But I do ask, and I'm speaking more probably as a city councilman of Sparks, knowing what's going to come my way is if we don't communicate well. But it would be really, this, as much as I always think moving forward's fine, if there's things shifting, whatever, I just hope we be really over communication and gentle in the transitions.
That's my intent. I did let the staff know today that I was a registered environmental manager for a very, very long time. So I am versed in the world of environmental management. I do have an engineering degree, so that caught a few of them off guard, which I thought was kind of interesting. I did have one of the supervisors go to the Enterprise Committee meeting the other day and just give them a heads up that there was a change and that I would be stepping in. And there's a number of those people that I already know because we work with them through the air quality side. So the engineering community has been reaching out to me also, and we'll take this momentum and see if we can't. I think the majority of the hard work has been done, so now it's just down to the implementation level, and I think we'll be able to get that.
Thank you.
straight.
Glad you're there.
Good. Yes, sir.
I just have great confidence in Ms. Elby's ability to perform these duties here too, and I think that her ability to deal with the public and the other aspects with contractors and things will be sterling, but I don't think all the other work's are already been done because there's going to be new things that are coming up, so I hope you like a challenge.
There's always new things. So. All righty. Thank you very
Thanks,
much.
Ms. Albee. Okay. Dr. Todd.
Good afternoon. Randall Todd for the record. I have just two things that I wanted to update the board on that were in my submitted report. We'll start with measles. You had some discussion on that earlier in the meeting. I checked just before coming to the meeting on the CDC website to see what the current national numbers are. And from January 1 through April 19, there have been 626 cases nationally. It went up 77 cases in just the 1 week. So that's fairly significant. And it's 626 cases in 22 states. Previously, what I put in my report, which was prepared on April 12, it had been 465 cases in 19 states. So it's going up fairly rapidly. By comparison, the highest year on record since 2000 was 2014, and they had 667 cases in 2014. If we're going up at the rate we've been going up, we probably, as of today, have already exceeded that, but we won't know until the CDC puts their official numbers out on their website. So, fortunately, here in Washoe County, we have not had a case of measles confirmed this year in 2019. That's good. We did have one last year in 2018. And you might wonder why that is. How are we so fortunate to be avoiding this? And I honestly don't know, but I have at least a partial theory. In Nevada, we do not have a personal choice exemption on vaccine. So California used to. They just recently got rid of theirs. So in some states, you can have a medical exemption, or you can have a religious exemption, or you can have a I just don't want to exemption. And California's had that for quite a number of years. So when I first came to Nevada and was working for the state, we had a bill in the legislature that was really a very simple little cleanup bill. All we wanted to do was make it so that the nurse could sign the shot record. Prior to that, only the physician could sign the shot record. We said it makes sense, since it's the nurse that often gives the shot, that the nurse should be able to sign the shot record. So I was a little bit amazed when I went in and signed in on the little sheet to testify before the legislature that there was somebody there ahead of me who had also signed in support of the bill, but it was an organization that typically is pretty anti-vaccines. And so I was, kind of curious to see what would happen when they stood up to testify, and they said, "Oh, we completely support this this bill. We have just one friendly amendment we'd like to introduce." And they said, "Well, what's that?" They said, "Well, we'd like a personal choice exemption." And so I argued strongly against it, and we beat it back in the committee. But then this group was able to get in front of the full Senate when it went before the Senate, and they got it reintroduced in the Senate. In the meantime, we had a case of whooping cough out in, if I remember correctly, it was out in Fallon. And I sent a disease investigator out there, and I said, when you go out to interview this family, take a video camera and get us some video of this child experiencing whooping cough. So he did that. When we came back and presented in front of the Assembly Committee, I decided I'm not going to testify. I'm just going to play the video. So we played the video. The Assembly Committee said there was no way they were going to support this personal choice exemption. And in fact, the Senate reversed themselves and got rid of it. So I sort of knock on wood that we don't have a personal choice exemption, but I don't feel too confident that we won't at some point in the future have to fight that battle again. And so I can't help but believe that that is helping us keep those numbers down. So right now, if you go to school, you've got to have your MMR, 2 doses on board. And if you don't, then you either have a medical exemption or a religious exemption, and you can be excluded from school. If there are cases that come up, you can be excluded while that's ongoing. So that's kind of the measles story here for now, and we hope it stays at 0 cases for this year. The other thing I wanted to just mention as an update from when I prepared the report, we are currently down from, and this is on influenza, so from our influenza-like illness, the 12 providers, the percentage is down from 2.4 down to 1.5. So we are getting back down near our baseline numbers, so that's excellent. We just, I think it was yesterday, I recommended that we remove the requirement for unvaccinated clinical staff to have to wear masks. And so we are at the tail end, we hope, of our influenza season. And with that, I would be happy to entertain any questions that board members may have.
Questions? Dr. Todd, would you mind giving us a short synopsis of what's going to be happening for the next week and a half as far as an exercise? Sure. We are, our public health preparedness program is, we frequently have to exercise because we thank goodness, we don't have real events happening that cause us to have to exercise these kinds of scenarios. But we are, I'm just looking to see if I wrote anything down about it. Sure, if you've got some information. But we are, I'll have Christina tell you all about it.
Christina Conti for the record. Our hospital preparedness program is funded by the ASPR grant, and federally there are a bunch of requirements that we need to do, and one of them is looking at alternate care sites. So if our facilities were no longer able to intake patients in there, where would we do this? And so the region has gotten together, and we are doing, it's over a 7-day period of time where the 3 major hospitals, Northern Nevada Medical Center, Renown, and St. Mary's, will actually be setting up a portable hospital. It's a state asset that is actually housed with REMSA, so they're going to be providing that training to our entire region of how to set these up, and that's going to start tomorrow. Then Monday and Tuesday, I believe, are the days. And then on Thursday, we're actually going to run a full-scale exercise out of those units at each of the 3 hospitals. So depending on what your day looks like Thursday, we would certainly invite you to go down. We're having a volunteer support, so there will be true patients of varying ages and degrees of acuity. And then we'll start the teardown on Friday. This is the first time for Nevada. We're a little bit ahead in those federal requirements that this is being done. So we're leading the charge on that, which makes us really excited. And it is a true collaboration and partnership with all of the coalition members because it's going to take a lot of people to get those set up.
Good, thank you. Questions? Good, thank you very much. Mr. Health Officer.
Thank you, Mr. Chairman. I just wanted to provide a few updates to my report on the public health accreditation. The site visit team had a conference call earlier this week to discuss our upcoming visit and the review of the documents that they've done. And we've been told that by the end of the month, by April 30th, we'll be notified of any of the document areas that they want to reopen. So that would identify for us if they think we need to look for other documentation for those domains. So we're looking forward to getting that information so we can respond to that. We're still scheduled for the site visit June 25th and 26th. I wanted to also just highlight the item I put in my report, the Substance Abuse Community Coalition Accelerator, and the event that we had on April 5th to bring together people across the region to work on how we can enhance our activities to address our substance abuse epidemic. And we had 53 participants from across the community, from not-for-profits, from medical and medical-assisted treatment units, from each of the governmental jurisdictions. And I wanted to particularly identify the new Sparks City Manager, Councilman Dare. Neil Kreutz came and he spent the whole day up until I think 2 o'clock. He had a 2:30 appointment. We wrapped at 2:30 that afternoon, but it was a great commitment that he made to be there and participate. So
cool. Thank you.
And we'll be following up. Excuse me. We'll be following up. We made some good progress in the breakout groups on strategies to move forward in the areas I noted in my report. And those work groups will be following up and working to further advance the momentum that they got during that day. So overall, a lot of good feedback on it. It was a successful event. I also wanted to thank Chief Brown and Councilman Dare for joining Health District staff at the Making Health Happen Awards ceremony that the UNR School of Community Health Sciences did, and that was on April 3rd. It was a really nice event. Councilman Dare is a party animal, so be careful if you're going anywhere with him. And I wanted to acknowledge both our sexual health program that was nominated for a government agency program award. They did not receive the award, but it's great recognition that they were nominated for that. And then I also wanted to congratulate Steve Cutts, who was the award recipient of their prestigious Community Partner Collaboration Award. And so we have a video of Mr. Cutts that they played that evening.
Hi, my name's Steve Cutts. I'm the Division Director of Community and Clinical Health Services at the Washoe County Health District. I've been in public health for almost 30 years, and I've loved my public health career. We have a wide variety of programs and services that we offer to our community. Clinical services such as immunizations, STD, HIV, family planning, and tuberculosis. And then we also have programs such as our chronic disease prevention program that focuses on policies, systems, and environmental changes. Some examples of those would be the Nevada Clean Indoor Air Act, smoke-free multi-unit housing, as well as smoke-free parks. We've been a longtime partner with the university for many programs, schools, and colleges. I myself am an Orvis School of Nursing graduate, as well as getting my master's degree in public health from the School of Community Health Sciences. I have been very appreciative of the experiences that I had as a student with the university, as well as what we have been able to offer students through the university.
My name is Lily Davalos, and I am the outreach manager for
We saw our star. That's all we need to see. So congratulations to Steve, and he's really done a tremendous job with the partnership with the School of Community Health Sciences and all of the interns and students that not only does he help educate at the health district, but he also teaches at the school as well. So congratulations. And then for Truckee Meadows Healthy Communities, I reported on the regional strategy for housing affordability, that there would be a presentation for the Regional Planning Agency Governing Board. That's going to occur on May 23rd, and there'll also be a community event to present that strategy. That'll be happening at 3:30 on May 23rd at the Joe Crowley Student Union up on the 3rd floor. And I don't know if it's running to 5:30 or 6, but somewhere around that. So if people have the opportunity to get over to see that, I'll forward out information as it becomes available.
Thank you.
So that concludes my report. I'd be happy to take any questions.
Very good. Questions? Okay. Moving on to board comments. Anything you want to put on an agenda or bring forward? Yes, sir.
I do. I just wanted people to know, and as this opens up, I'll be more informative. I'll be on the governor's task force for the census, and I know that'll affect a lot of different things. So I'm honored to represent cities, and so I'll be doing that. And so as things go, I get to help put that together. So
good. Thank you. Anything else? One thing today, I went to a meeting on this exercise that's going to come along, and it is a full-scale, full-blown exercise. We're one of the first counties, agencies in the country to do something full-scale like this, setting up the mobile hospitals and everything else. We're here. We're going to practice it. It's a great scenario. We've got stuff going out to the media, but I just was absolutely amazed. The organization, the amount of work is being put in by Andrea and Brittany, and this whole thing is just going to be an amazing big thing. So over the next couple days, they mentioned that they're putting up, these mobile hospitals, and they will be fully air conditioned and everything else, that you may want to swing by one of the sites and take a look at what we're doing. So we've got a lot of things to be proud of with our health board here. So.
Chair, can we come and be sick? Can we be like bloody sick people and be carted around? Oh, I would. Yes. I'm in. That's exciting.
This is not the party animal group.
Oh.
No. Yeah, contact.
Who wants to join me?
Contact Andrea. She's good. Do we have any more public comment? Okay. I will take a motion to adjourn. So moved. Second? All in favor?
Aye.
Aye.
Thank you very much. Mr. Cutts, you did a great job of sandbagging the meeting for 38 minutes. So.